a paper. Long talk. I want to have participation by you, and the first thing is everybody stand up, please. Sorry, because you've all sat down for too long. Breakfast was a couple of hours ago. Can anybody see the side on that? Anybody read what it says? This isn't an eyesight test. Gentamicin. If you have prescribed gentamicin, sit down. Good. Right. Everybody stand up again. If you have prescribed morphine, sit down. This drug. This is paracetamol. Stand up again. If you've looked after somebody who's had an overdose from paracetamol, sit down. Pharmacology is important. And it's usually left to 15 minutes at the end of a 5-year medical school course or something like that. And so therefore, what I'm going to try and do in 30 minutes or so, is 30 minutes-ish?
Yeah, whatever you want.
So in 30 minutes, we're going to try and... my timer went off. In 30 minutes, we're just going to try and address some of that balance and talk about why pharmacology is important. I'm going to break every piece of equipment in the room. Okay.
Turn it on again.
Am I back on? Yeah. I'll put that in my pocket then. Because essentially, if you've prescribed anything, then this is the talk that you need to know. Okay. And what I'm going to try and do, rather than going through lots of example questions, there will be some examples within it. But what I'm going to try and do is illustrate the basic principles, which are not that hard, and then you can work it out for yourself. And it's all about getting medications to get the job done. And this is not a cute baby, okay? This is a clinical problem waiting to happen. And how we solve clinical problems is we give drugs. And what we want to know is, how do we get the drug into the baby, which is absorption? How much drug do we need to give, which is all about volume of distribution? How long does the drug last for? That's all about the clearance of the drug. And how does it work? And that's the pharmacodynamics. And that's all you need to know is 4 things for each drug, and then a bit about side effects and everything. But the basic principles hold for all of the drugs. You can't see this, but through the background there is a creepy, scary house. It was Halloween a while ago. This is how we think about pharmacology. It's a scary thing. We don't really want to think about it. This is when you get the postcard from your friend to go away for the weekend to the scary house and nobody survives. And what we're going to do is we're going to have a look at the various things from the scary house and show that they're not actually that bad. So the first thing we're going to do is absorption. So absorption is essentially how you get your drug into the patient's body. And the neonatologists have it easy because they pretty much give everything intravenously, and that completely bypasses absorption. But for the rest of us working in outpatients, we tend to give things orally, or we tend to use other methods of giving them. And that means that not all the drug that you give somebody by mouth, because most drugs are given by mouth, even though I'm a respiratory guy and we sometimes give inhalers, most drugs are given by mouth. And what we want to know about is how much of that oral drug that you give ends up in the patient. So this is the example of 100% bioavailability because you're giving it intravenously, all of the drug ends up in the patient. You give 100 milligrams, the patient gets 100 milligrams. When you give something by an oral syringe, then you end up only get a fraction of that drug getting into that patient. And just to illustrate how this can influence your total body content of drug, you can look at the absorption and you can see how it might vary for different individuals. If you have a term neonate, the gastric pH, depending on where you measure it from when they last fed, can vary very widely from very low to very high. So if you've got a drug that requires a low pH to be absorbed, and your patient has a high pH at the time, you have reduced bioavailability for that particular dose. And then you have various other things that also affect bioavailability, such as the gastric emptying time. If it's something that's absorbed from the stomach and they've got a high gastric transit time and they empty quickly, you're going to get less bioavailability. If you've got reduced intestinal surface area, like in a small child, especially in a neonate, then you get reduced absorption of the drug. And similarly, there are things like enzyme systems that are transporter mechanisms that are responsible for the uptake of some drugs, and they vary. And why is this important? Well, the idea for a long time was that if you have a big person, like a 70-kilo male medical student where most drugs are tested, and then you just have to drop that down to something, a fraction of the size for the baby, and of course that doesn't work. And to give you an example from the literature, so occasionally I moonlight on the paediatric intensive care unit, and if you've ever worked there, you might have given oral clonidine as a sedative medication. And the Scandinavians are great at churning out papers like this, so this is from Scandinavia, where they looked at what your oral bioavailability was after giving a dose of clonidine. And because it's on the intensive care, they might have IV access devices, so you can take numerous blood levels. And your bioavailability is proportional to the area under each curve. And each one of these lines represents an individual patient's measurements over time. So we have some people who we give it, and they have huge peak plasma concentrations, and it comes down quickly. And we have other people who it builds up slowly and comes down. And when you look at this on average, it turns out that 50% of the drug that you give orally ends up in the patient's body in the systemic circulation. And then if you then compare that to adults, 75% of an oral clonidine dose on average would end up in a patient's systemic circulation. So you can see how in children you actually have to give a higher dose than you would expect just from scaling it based on the body size. And this is one of the examples. So absorption issues can contribute to you having to use different doses for children. So that's absorption, and it's relatively straightforward. How much do you give? How much ends up in the systemic circulation aren't 100% correlated. Volume of distribution in our creepy Halloween slide is a little bit more tricky, but we'll go through it, and it's actually straightforward. This is how I think of our clinical problem, which is our 1 kilogram neonate. You should forget the pretty slide of the cute baby that you'd put on your promotional unit for your literature. This, to a pharmacologist, is a 1 kilogram neonate. Okay. So in that 1 kilogram neonate, you have approximately 80 mils per kilo of blood. And so what you can then do is you can say, well, about 32 mils of that is plasma-ish. And all neonates will vary, but this is kind of where we are. So if we take a drug and we give 5 milligrams of it per kilo, because I made this a 1 kilo baby, it makes things simpler. You'll thank me for that. Okay. So if we take our baby and we give them 5 milligrams per kilogram, or 5 milligrams, what you then want to know is how much will the plasma concentration of the drug be? How high does the drug go? So this looks like a really nice and simple sum. The peak concentration should be 5 milligrams in 32 mils. Yeah? And then you take your 5 milligrams, you divide it, we want it in litres because that's how it's reported. You divide it by 0.032 litres, 32 mils, you get 156 milligrams per litre. That sounds enormously high. Nowadays this is gentamicin, okay? So has anybody ever measured a peak gentamicin level? We tend not to do it anymore, we tend just to measure troughs. But I ran a clinical research study looking at tobramycin peak levels, and this is enormous. So
I did gent peaks, and there'd be 10 was getting a bit worrying.
Yeah, exactly. So 10 would be how high we'd want it to be at most. Okay. So what's going on here? We've given a dose that you and me, we've all prescribed gentamicin. We know that this is an appropriate dose. We know that we give it for kids who are about a kilogram, so that we've got sort of a 1 litre baby, What's actually going is it moves. And when I say the word move, you could replace that with the word distributes through the water-soluble tissues of the baby. So gentamicin is relatively water-soluble. And what that then means is it turns out in a baby, there's about half a litre of water if you've got a 1 kilo baby. You can do this more accurately for different ages of prematurity and term. But let's imagine, for argument's sake, there's about half a litre of water. Then what you can say is maybe that 5 milligrams has spread evenly through that half litre, so half a litre per kilo, and that's ended up with our 10 milligrams per litre in our blood volume. So it's moved out of the blood into the rest of the baby. And it does this really quickly. So if you measure your peak level within sort of half an hour after giving the dose, this is kind of where the distribution has happened. Okay. So what we've just done is solved the volume of distribution problem. So the volume of distribution is the apparent volume of the drug that a drug would have to distribute within in order to give you that measured concentration after you've given it a bit of time after giving the dose. Okay. So we give our dose, we wait a bit of time, we measure a concentration, we know how much we've given, and then we can work out the apparent volume that we've dissolved it in. And why is this useful? You know, we make you learn this just because we're cruel? No, we make you learn this because it allows you to calculate a loading dose to achieve a target concentration. Okay, and that's why we want to do it. So if I show you this slide again, so the volume of distribution is the amount that you've given divided by the plasma concentration. So what we can do is we can rearrange that. We'll just swap it to the other side. So we put the amount and the plasma concentration on the left and the volume of distribution on the right. And then what we want to know is the amount of drug to give. So then we can take plasma concentration, move that up here and multiply it. And so we can say that the loading dose that we need to give is the plasma concentration multiplied by the volume of distribution. And this is why we make you learn this. And it's a very simple equation to then do. So we want to give, to have a plasma concentration of 10 here, and we want to have, and we know that the volume of distribution is 0.5, and that tells us that our loading dose is 5 milligrams per kilogram. And that's the only reason why you need to know what volume of distribution is. There are other esoteric things for pharmacologists and stuff like that, but as a practical paediatrician, that's what we need to know.
So can you see how easy it is to write a question on the loading dose would be given by the plasma concentration times our volume of distribution, correct? And then volume of distribution divided by plasma concentration. Volume of distribution times plasma concentration to the power of 2. You know, all the other possible distractors. And prior to seeing this lecture, what would you do when you saw that question? Panic and pick any of the following options as being possibly correct, thinking I'll go on and do another question. Yeah? But it's not impossible to work out, it's easy.
There's only 4 equations really, and if you can remember that one at the top, and then you can rearrange it, then that's about 50% of the equations you need to know. There are some pitfalls involved. Sorry. There are some pitfalls in volume of distribution, and one of them is sometimes you give a drug, you measure the plasma concentration, it's so low that it's distributed into something that's bigger than the baby. So this is a baby who's 1 kilo who has a volume of distribution for a drug that's 4 litres, and that can't possibly happen. And what's actually happening there is that your drug is really fat soluble or highly protein bound or disappears off somewhere where you can't measure it, like into the sputum of the lung. And then what that does is it drops your plasma concentration. So you give your drug, drops your plasma concentration because it all ends up in this other potential space somewhere else. And that's what's happened when you've got a really high volume of distribution. A really low volume of distribution, you've got high movement of the drug to another compartment of the body. And that's really all I'm going to say about multi-compartment models, because we've got to, but that's, so if you've got a very, very high volume of distribution, very low plasma concentration, after giving a big dose of a drug, it's gone somewhere else in the body. So we've kind of we can see that this scary thing called pharmacology is gradually becoming easier. Okay, so the bulk of the talk is coming up now. Okay, and this is a bit that's trickier and the hardest bit to understand. So I'm going to try and do it in 2 different ways and explain how clearance, metabolism, half-life, and all of those kind of things that make you panic and just flip over work. So if we go back to this slide where we have clearance, what we've got to do for any drug is you've got to put it in, it's got to go into the plasma, it might distribute somewhere else in the body, comes back again, it goes out, and the liver and the kidneys get rid of it. Okay? So what we're now talking about in clearance and half-life and metabolism is getting it out. So far we've got it in, we've worked out where it goes, now we're getting rid of it. So I want you to imagine this is our patient again. All of my patients are square. And this is where the drug is. And the concentration of the drug, imagine we've given a drug that goes throughout the body and it's equally distributed wherever it is. So if you punch biopsy my skin, the concentration after I've taken this drug is the same as if you take a biopsy of my brain or a blood sample. Imagine it, just for argument's sake, that it's very straightforward. clearance is how you clear the body of that drug. And what clearance as a concept is that every hour, or every defined period of time, but let's keep things simple, every hour what you do is you take a proportion of the blood out of that patient, stick it in the lab, remove all the drug out of it, drop it back into the patient again. So that's us taking that bit of the blood out, cleaning it all, and then when we put it back in, we get a slightly lower concentration of the drug in the body. Okay. And then we do that again, so we clean out that same amount of blood of that drug, and we get slightly lower concentration when we put it back in. And this is what our kidneys are doing all the time. They're taking some blood and they're cleaning out some of the drug. And the clearance is the volume of blood that's removed. So before we've got, so the clearance is the volume of blood that is completely removed of any drug in it. So we'll do the definitions more carefully in a moment, but I want you to get this feeling of what happens when you clear a defined amount of blood of a drug. So what we can show is how this cleaning out of the blood, or clearing, is related to half-life. So imagine we've got this patient and we clear off 20% of their blood. Okay. Their plasma concentration here will drop by 20%. And then in the next hour, if we clear out another 20% of their blood, their plasma concentration will drop by another 20%. And then the next hour we clear out another 20%, their plasma concentration will drop again. And we keep on doing that. And what you can see is each time the concentration after every hour has gone down by 20%. And this is just for this particular drug, the clearance is 20% of the blood volume or something like that. And what that means is that you never really ever get down to zero. Okay? And you can see how you could draw this line here. And this is what you call an exponential decay line. Okay? And why this is important is it tells you two things. One is the amount of the drug that you get rid of is proportional to the amount of drug in the body. And this, you've all seen this curve before, because it's the same curve that you would use, in paracetamol overdose. How quickly is it leaving the body? It's the same curve when you're calculating drug levels, if anybody uses nomograms for funny drugs. So, using this, we can define the terms a bit more carefully. So your clearance is the volume, and you can express clearance in different ways, but usually it's plasma that's completely cleared of a drug in a given time period. And for babies and kids, we'd usually express it per kilo, but you can express it in multiple different ways. So 10 mils per kilo per minute, or 5 litres an hour, or 1 litre an hour, or something of that nature. Okay. And the half-life is much simpler. The half-life is just the time taken for the drug concentration to decrease by half. Ooh, sorry. So you calculate that, your half-life, accurately using the volume of distribution and the clearance. So this is the other equation that it's useful to know. So your half-life is 0.693 multiplied by your volume of distribution divided by your clearance. Okay. And 0.693 is just a magic number. It's a logarithm of 2. You don't have to worry about why that exists. For our purposes, we'll just say it's there and we'll leave it there. But if you know the volume of distribution and you know the clearance, you know the half-life. So what that means is if you're given a question which says, okay, you take a drug and the half-life of the drug is 3 hours and the concentration is 10 milligrams per litre, how much will be left after 6 hours? You just divide by 2 and then you divide by 2 again because that's 2 half-lives. So it's quite straightforward. So this is what we call first-order kinetics. And this explains pretty much all of pharmacology when a drug is in the systemic circulation. And then this is useful facts that could be easily tested in exams. So I mainly use pictures, but the half-life determines the time to steady state. So if you're giving a multiple dosing regimen or something as an infusion, you achieve steady state in 3 to 5 half-lives. Okay? If you only give a one-off bolus of a drug, it will hang around in the body for 3 to 5 half-lives, and then it's gone. And you can calculate that yourself. So you take 100%, you divide by 2, you divide by 2, you divide by 2. Pretty soon you're down to like 2.5%. Okay. If a drug is given every half-life, the plasma concentration changes a lot during dosing. So, for instance, if you had 10 milligrams per kilogram and you're giving a drug every half-life, so if the half-life is 5 or 6 hours and you give another dose, you know that you've gone from 10 milligrams down to 5. You give another dose, you get back up to 10 milligrams. It's a factor of 2 how quickly it's changing. So what you want to have for drugs is a pretty long half-life. 24 hours would be nice for orally bioavailable drug, because then you could give two doses in 24 hours. It means you have a very nice, smooth, lower dose kind of curve. So with drugs with a low half-life, like oral morphine, that's given every 4 hours in the BNFC if you use Oromorph. And that's why the more longer-acting versions of morphine are around, so we can give it much smoother. And that's essentially the motivation for making modified releases of almost all drugs. It's all about the half-life. And this is just illustrating why clearance and half-life are useful. So you can kind of see how this is looking at the half-life of a drug that we're giving. And we've got up to given 4 or 5 doses, and then we've hit steady state. And then you can calculate some other interesting properties. So the Cmax and the Cmin are the maximum and minimum concentration that you achieve during dosing. So you could see in a multiple choice question, if you've got a short half-life, the distance between the Cmax and Cmin will be wide, Okay. Whereas if you've got a long half-life, the difference would be low, So you can see how it's quite easy to write questions that if you stop, think, and then think again, you can answer them. So clearance is, apart from the practicalities of having to pass the exam, is useful in day-to-day practice as well. So this is our patient again. They're still square. And we know that they clear 25%, for argument's sake, of their body of a drug, every hour. That tells you how much you have to give every hour to achieve a steady state. So if you know that they've lost this amount, you just have to give it back. So this is the third equation that's useful to know. So the dose rate that you have to give equals your target concentration multiplied by your clearance. So if you've got a baby on the neonatal unit who's always awake, despite being on 20 mics of morphine, it might be that your central line's not working, but it might be also that they're getting rid of the morphine really quickly and they need a higher maintenance dose to replace what their body is clearing. And we've all met those patients. They're a nightmare. They pull the tubes out all the time. The other thing that's useful is calculating a maintenance dose of aminophylline. And so this is kind of what you might think will be a worked example. So for argument's sake, we might be aiming for 10 milligrams per litre in a 20 kilogram child who's come in with an asthma attack. And we know from the literature and from the question that the clearance is 0.087 milligrams per kilogram per hour. So our dose rate then is the target concentration, which is 10, multiplied by the clearance. But what you have to notice is this is litres per kilogram per hour. That should say litres. Apologies. And the dose rate here is 10 milligrams per litre, and you multiply that by 0.087, and you multiply that by 20, and that's the bit that everybody forgets to do, and then you get a dose rate. That makes sense? It's slightly more tricky to calculate clearance and half-life when you're using a maintenance oral dose. And in this case, your maintenance dose in milligrams is the same, the steady state concentration you want to achieve, multiplied by your clearance, but then you've got to take into account the fact that you're not giving a continuous infusion, you're giving something at intervals, and you also need to have your bioavailability as well factored in. So you divide everything by your bioavailability, you multiply by your dosing interval. And so that's just how the equation changes. I want to explain now why, because that's all quite hard work, why when you get drunk, it takes ages to sober up. Anybody here been drunk? One or two of you may have, one or two you may not have. Anybody seen somebody drunk? Hundreds of them around, especially in A&E. So first order kinetics is like this. So let's think about our half-life of something. If you got twice as drunk, let's say you were going to get me drunk and I had half a bottle of vodka, and then you got me the next day and I had twice as much vodka, you would think that being twice as drunk would mean that it would just take an extra half-life for me to sober up, because it comes down by 50% for every half-life. Yes. And my half-life for alcohol might be different to anybody else depending on how much we all drink, how cirrhotic my liver is, how cirrhotic everybody else's liver is. The problem is there's one or two drugs, and alcohol is one of them, that have something called zero-order kinetics. So this is called first-order kinetics, and this is called zero-order kinetics. So almost every drug you will come across is first-order kinetics, but these are the ones where there's a small, very well-defined route to getting rid of the drug, and you can only get rid of the drug through that route, and it's only got a certain capacity. So the amount that you can excrete in an hour is not based on how much is in the bloodstream at the start of that hour, it's based on the capacity of the body to get rid of it, and this is why it's linear over time. And drugs which do this are things like alcohol, phenytoin, and salicylates, and the salicylates are in high doses. So this is your zero-order kinetics question. So if you're told in a question zero-order kinetics, the half-life doesn't make any sense for these drugs because that property does not exist. Because, this is where you have a half-life. So I thought it would be useful just to touch on how we get rid of drugs and how does clearance actually occur. So there's renal elimination and there's liver elimination. And so this is just going into them in a bit more detail. So liver metabolism basically makes drugs more water soluble. And it inactivates compounds and it aids the renal excretion. So there's one or two drugs which go straight into urine and are excreted directly. Things like some of the antifungals, aminoglycosides, that kind of thing. But most things end up getting metabolized by the liver before they're excreted. And there's two different phases to this. There's phase 1 and phase 2. So many drugs will go through a phase 1 step and then a phase 2 step. And then in the phase 1 step, this is where you change the structure of the chemical that is your drug. And so almost all drugs are oxidated. So I would say if you're unsure about how something is removed, if it's not an obvious one, oxidation might be a good bet to go. And there is an enzyme called cytochrome P450, and it's a group of enzymes. And in physiology, you're taught that there's an enzyme with a lock and a key, and the one lock fits the one key. Actually, most of biology isn't like that. There's whole groups of enzymes that are promiscuous and will act on many different chemical species. And cytochrome P450 is a family of these that do this. And they will have a go at oxidating anything that comes along. And so many drugs are oxidated by this. And there's several common families. So there's ones that break down caffeine and theophylline. There's ones that break down your things that make you happier. And then there's other ones that there's CYP3A4 does everything. And you may or may not have to remember this list. So A2 is your coffee. This keeps you happy. And this is, I don't know what Nofberk is, but that's how I remember that list. So nifedipine, ontonsin, fentanyl, benzos, erythromycin, rifampicin, carbamazepine, Nofberk. So it's just useful. And then there's phase 2 of the hepatic mechanism is where you add something onto your chemically altered drug, and this makes it more water soluble so your kidneys can get rid of it, because kidneys are great at getting rid of anything that's water soluble. And there's a few different enzyme systems like UDP, glucuronolacryl transferases, and glutathione S transferases. But basically, what might be useful to know is glucuronidation works on paracetamol of morphine, and sulfonation works on paracetamol. And these are the common drugs that you come across. And this explains, of course, why if you're in liver failure, you give somebody a dose of morphine, they're analgesed for quite a while. I had a friend who gave somebody lorazepam in benzo. I think it was lorazepam, or one of the other benzos, and he was in liver failure, and they hadn't realised, and he didn't wake up for 3 days on the ward, and we teased him for 2.5 days until his patient woke up, but he was quite worried at the time. So it's always good to know if a patient's in liver failure before you give them some drugs. There are various different age things that happen in terms of the development of your liver and in terms of how you deal with drugs. There are tables like this in many pharmacology textbooks, but things that I thought you might want to know would be that there's a postnatal pattern of development where the levels are initially low and then ramp up over time, and that affects things like caffeine and theophylline. And so that would contribute to why you might not have to give a huge dose of those drugs early on in life. And then there's chloramphenicol causes the grey baby syndrome if you give it in too big doses in babies. And part of the contributing factor to that is that UGT2B7 is one of these enzyme systems that doesn't work very well at birth and then ramps up over time. And so for that reason, it's useful to know that there are patterns of age and metabolism. So I was going to very briefly talk just a couple of slides about therapeutic drug monitoring because it's useful here in life and it may well be something that could come up in an exam. And here what I've done is I've plotted two different patients. For gentamicin, what you want to have is a really high peak serum concentration because a high concentration kills off the bugs. And what you also want to have is a low pre-dose level, and you want to get down to 0 after every dose. And the reason for that is that the area under this curve, if this is time and this is serum concentration, the area under this curve is proportional to the toxicity that you're exposing your patient to. So the bigger this area, the worse. So you can see how we've got this patient in dark blue and this patient in kind of a funny lilac-y colour. And the dark blue patient has lower elimination but still gets down to 0. So our therapeutic drug monitoring would say actually this patient is probably okay, but they've got quite substantially more area under the curve than this patient who goes up and then goes down with this lilac colour. So what happens if we give a dose before it's got down to 0 is you end up with this dose stacking phenomenon, and this is really bad because if you look at the area under this bit of the curve here, it's huge, and this patient is about to go into kidney failure. So what we want to do is avoid that from happening. And the approach to take is our peak concentration is fine, so our bacterial killing is good. What you just do is you just delay the next dose. And this is where we do extended interval dosing. So you could go up to 36 or 48 or 2 days. And, you know, our nephrologists occasionally use aminoglycosides and they'll give a dose once a week or something like that. So this is completely different from what you want to achieve with vancomycin. Okay. So in vancomycin, you want to have a constant level that's high enough such that you've always got it there stopping the bacteria from growing. So vancomycin doesn't have a handy post-antibiotic effect, which gentamicin does. So that bacterial killing is related to making sure you get over this line here. So for that, you do want to dose stack and you do want to get it high. And you notice that elimination is proportional to the amount of drug that's in the system. So the half-life stays the same, but every hour at higher levels you're clearing more. Okay. So that's clearance and metabolism. It's still a scary place, this place that we've been invited to for the weekend of pharmacology. But we'll talk about agonists and antagonists. So this is the classic model of how drugs work. So you have a receptor, and for some reason everybody wants to talk about the beta receptors because that's, you know, hypertension in adults, and who gives a damn about adults? But we'll use that example. So here we've got a chemical species, and it fits inside a receptor at the cell surface, and when it locks into that, it causes something to happen downstream. And so this is what you call a competitive agonist. It goes locked onto it, does its job. Antagonists can come in a different couple of forms. One is a competitive antagonist. This is where it gets into the receptor of the cell, gets into that onto the active site, but it doesn't trigger all the downstream effects. So it's in there, but the receptor isn't doing anything. And whilst it's there, it prevents anything else from landing on it. And then you can have non-competitive things. So this is where you can have your normal molecule landing there all the time, but because this is latched on somewhere else, it stops this receptor from doing its job. So this is the mu receptor, or it's a cartoon of the mu receptor, which is the pain receptor that morphine latches onto on all the opioids. So it's a transcutaneous cell membrane, transmembrane receptor, goes through it a few times. Your agonist lands on this side, and it's a G protein coupled receptor, which means that the machinery underneath the cell is common to a wide number of different receptors, and it ends up causing what you call downstream effects of doing various things. And the nice thing that we want it to do is to block pain. So what we want to do is to land something there that will stop things from working, and so turn off things, and then you get pain relief. And there's this concept of full agonists, partial agonists, and so on. So to explain this graph, this is how much of a chemical species of our drug that we put into the system. And this here is a readout of how well the drug is working. So if you were looking at trying to prevent pain transmission, 1 would be brilliant. You've maximally stopped pain transmission from happening. So we turn up this amount of drug. This is where there's nothing in the system. We turn up the amount, and this is where we've given morphine, and we've got 100% efficacy, and it's working really well. We've got weaker opioids, like codeine, who are partial agonists or metabolites of codeine, and so they might go on this line here. And then there's naloxone. So naloxone will bind with it, and it reverses the action of morphine. And the way that does is it binds with it, and it stops the morphine from working. Now, I don't want to overcomplicate things too much, but in certain circumstances, some membranes, some cell membrane receptors are always slightly turned on all the time, so they're constantly having a small downstream effect. And so what you can have is a negative agonist or an inverse agonist, where you do the opposite of what the agonist would do. So most competitive inhibitors, this kind of system, would just carry on at 1, and then you add this and it doesn't go up. But occasionally they can turn the whole thing down. So that would be naloxone, which is not only a negative, a competitive antagonist, but it's also an inverse agonist in that it does the opposite. And this could also be like, there are a few other examples in the literature. So some of the GABA receptors express this property. And this, I think, in the next 10 years is a huge area of research for many pharmaceutical companies, because this property has only been known about for 10 or 15 years. And so the pharmaceutical industry is going to try and exploit inverse agonists a lot. So it's something that you might need to know about for the future. The final thing that I'd like to show you from this section is just about how big the cell surface molecules are, and the molecules are in the cell compared to how big our drugs are. So this is the ribosome. This is the bacterial ribosome, which is tiny compared to the human ribosome. And if we zoom in on it, we can chop away. We have to slice the front, because the grey bit is where we've had to slice into the molecule to get to where we want to be. This is gentamicin in the middle. So our drugs are orders of magnitude more microscopic than the proteins and the cell surface receptors that are more complex than proteins that we're trying to affect. And to me, it's fascinating that such a tiny thing here will stop this ribosome from working. And that's the beauty of these systems. And I thought it would be useful for you to think that there's not a huge degree of difference in the structure between morphine and naloxone and those kind of things. And these tiny differences can make huge differences for cell behavior. And that's all of pharmacology, really. So this is what we've done. We've talked about absorption, how you get the drug into the system. We've talked about volume distribution, how big you need your dose to be. We've talked about clearance and metabolism, which is how you get rid of the drug. We've talked about agonists and antagonists. And you can see how, from first principles, you can work out much of this just by knowing 3 or 4 equations and a few basic principles. And so our scary haunted house is actually a really nice getaway weekend. There's no need to be worried, guys. Finally, if that didn't tell you that this is brilliant and you should study this for the rest of your lives and maybe dedicate your most productive years to pharmacology and pediatrics, it's important to know PK for rational use of antibiotics. Pharmacokinetics is right in the middle of the things that people get wrong. generally speaking, it's poorly understood and it's really easy to write questions on. And people tend to be worried about it. People always leave it at the end of books, but fortunately it's in the middle of this book. It's important, you know. Normally I talk at 4:30 on a Friday afternoon, you know, and nobody's there. And in the exam, everybody's like, well, I don't have time to sit down and work through these options and do some sums and calculations. But actually you do. Everybody finishes about 10 minutes before the end. So you could spend that 10 minutes just doing some sums and getting the easy marks that these often represent. Because if you've learnt those 4 or 5 equations, they're often quite straightforward marks to get.
That's real data